Okay, so if we're going to start off here, the question is, which of the following most accurately defines an allergic reaction? Just off the top, reading them real quick, anybody know what the answer is? The answer is A. Okay, so let's look answer by answer. A says an exaggerated immune system response to any substance. Okay, we know that's correct because your allergies are your body's own reaction. So allergens come in, your body's trying to get rid of them in multiple ways, everything from your skin, which protects you, your mucous membranes, hairs in your nose, things like that. An allergic reaction is an exaggerated response. Obviously, an anaphylactic reaction would be an extremely aggravated response. It's just on the continuum. B says destruction of the immune system by an external substance, and that's not correct. It's overaction of the immune system. C is likewise wrong. It doesn't mention the immune system at all, and neither does D. So the answer is A. Number 2. You are caring for a conscious, confused patient with left-sided hemiparalysis. His airway is patent and his respirations are 22 breaths per minute with adequate tidal volume. Treatment for this patient should include what? So before we look at the answers, let's look at what we have in the question. What do we know about this patient? Okay, conscious but confused, so maybe a little bit of altered mental status, keep that in mind. What else? Left-sided hemiparalysis, or you might see that written hemiparesis other places. And then what do we know about his breathing and his airway? So his airway is good, his breathing is good, maybe like a tiny bit fast. We know the range is 12 to 20 and 22 is just outside of that, but not extremely outside of that, right? So based on this, based on the question alone, what do we think we could do for this person? Remember, your first or one of your first considerations for every single patient is airway breathing, specifically what you're going to do with oxygen. For this patient, does he need oxygen? You give oxygen to every patient. So the answer will always be yes. There's never going to be a question on this test on the National Registry where you don't give oxygen at all. Like if that's one of the options, it's going to be in the answer. If you look at these answers now, every single one of them has oxygen in the answer. So we know we're going to give oxygen. The question is how we're going to give oxygen. Okay, so because he's getting adequate tidal volume and his respirations are at an adequate rate, he doesn't need something more extreme. He doesn't need a BVM. He's breathing just fine by himself. So if you look at the answers, which answers can we immediately cross off? B and C, because they both include a BVM, and we know we don't need that. What does that leave left? A and D both have oxygen via non-rebreather. What is the difference between those two? Okay, so it's a positional difference. We either have the left lateral recumbent position, which would be laying on your left side, or we have the supine position with legs elevated, which would be laying on your back, legs up a little bit. That's what we use for treating shock, typically with patients. What would you say for this particular patient? Between those two options, is there any idea which way you would go? Correct. Because he has left-sided hemiparalysis, you would not want to put him on his left side. That's the side he can't control. You can't depend on those muscles to properly hold him up. You'd want to go ahead and put him supine. Of the two options, that's just the better one. So the answer for this one is D. 3. A young female presents with costovertebral angle tenderness. She is conscious and alert with stable vital signs. Which of the following organs is most likely causing her pain? This is basically going to come down to vocabulary. So we're looking at these organs. We need to know where they are in the abdominal area. Any ideas what costovertebral angle is? Okay, so breaking it down, it's okay, but breaking it down into its individual word parts, vertebral, what are we talking about? Vertebrae, so we're talking about the spine, right? We're talking about some angle that something makes with the spine. We talk about costo. Does anybody remember the costal nerve, the costal ridge, the intercostal arch, intercostal muscles? Any of these things ringing a bell for anybody? All these different... Okay, so yeah, you got one. Intercostal muscles are the muscles between your ribs. That means anything relating to costo or costal has to do with your ribs. So you're talking about the angle between your ribs and your spine. That angle would be on your back. You've got your spine going straight. You've got the ribs that kind of come down at this angle, right? and then swoop around into the front. So what organs are there in that angle? Your kidneys. And if you look at the answer, that would be answer B. Knowing where everything else is, your liver is kind of up in the front over here. Pancreas is tucked behind your stomach. It's only on the one side. And then your gallbladder is tucked underneath your liver, kind of under and like slightly behind. So none of those would really make sense in terms of being this, what do they call it, the costovertebral angle. Because the kidneys specifically, they're in that retroperitoneal space, which means they're actually behind the abdominal cavity. They're actually in the back. They're like kind of right next to that, right next to the spine up in that area. Okay. Number 4, a 62-year-old male presents with crushing chest pain, which he describes as being the same kind of pain that he had with a previous heart attack. He has prescribed nitroglycerin, but states that he has not taken any. After administering 100% oxygen and contacting medical control, what should you do? Generally speaking, what is our procedure for nitroglycerin? Okay, we can help him. He has it prescribed, so we could give him some according to his prescription, right? Throwing out some stuff, so you contact medical control. What will they ask you when you ask if you can give nitroglycerin? What's important? His blood pressure. So what do they want to know about his blood pressure? Right, systolic being above 100. If systolic is below 100, no bueno. So it has to be at least 100 for the systolic number. If systolic is above 100 and he has it prescribed and he hasn't taken any, more than likely they will tell you can go ahead and give it to him. Based on that general procedure of nitroglycerin, or rather, let me finish. After you've given it to him, what do you do? In about 5 minutes or so, a few minutes, reassess the blood pressure. So based on that procedure for nitroglycerin, which of these answers makes sense? B, right. A, it's not that it's wrong, it's just it's not the thing that you would most immediately do. If you can give nitroglycerin and he has nitroglycerin and he needs nitroglycerin, you wouldn't completely ignore the nitroglycerin and just start transporting. Like, that's an easy thing you can do to help him. If you're allowed to by medical control, which is, it says you're contacting medical control. B is correct because, again, you can assist him with the nitroglycerin unless his systolic blood pressure is less than 100. So don't get confused by the wording on that one with all the unless and less than. Just remember, systolic has to be higher than 100 and read it carefully. C is definitely wrong. Why? Yeah, you wouldn't just kind of give a whole bunch of a drug and just and then see, oh, I wonder what happens now to the guy. Like, he's dead, congratulations, because you didn't check after each time. So you want to check every single time. That's part of doing your job correctly. And D, why is D not exactly correct? Yeah, it's not 72 hours. 72 hours is too long of a time period to worry about. So you do need to ask. Remember, that's one of the contraindications of nitroglycerin, if they've taken Viagra or any other nitrate-containing medication in the past 24 hours, but you don't need to worry about the past 72 hours. Number 5, you receive a call to a local daycare center for an unconscious 8-month-old infant. Upon arrival, you perform an assessment and determine that the infant is not breathing. After delivering 2 rescue breaths, what should you do? Okay, so looking at these answers, which one of these, well, they're all but one of them are wrong. Does anyone have an idea which one's right? A is correct, yes. Okay, so remember, for infants, we take the brachial pulse. What do we take for adults and older children? Carotid. If you've got an unconscious adult or older child, you take the carotid pulse up in the neck. Infants, we take the brachial pulse because it's simply easier to find. Because infants don't have much of a neck, and it's usually surrounded by lots of rolls of cute, pudgy fat. And so you want to get to something that you can quickly get to and accurately take a pulse. And so for infants, the brachial pulse is great. Everyone can find their brachial pulse, right? You need to be able to, on yourself, you should be able to feel it. Certainly on kids, it's pretty easy to find. It's a good pulse to be able to know where it is. So brachial pulse is the way to go. Remember, you've already given 2 rescue breaths real quick. That's because you know for a fact they're not breathing, so rescue breaths right away, bam, you take care of that. You give them a little bit of oxygen, but you also want to check for pulse. You don't want to just only look at the rescue breaths and not treat the possible cardiac compromise, right? You can't just do one and completely ignore the other. Yes, if they don't have a pulse, you need to start doing something, but B would be wrong because at that point you haven't taken a pulse yet. Yes, so you know they're not breathing, so you gave them breaths. You have to check for pulse before you can give them compressions. You can't just go, okay, not breathing, I'm going to go ahead and give chest compressions because I assume that's what they need. That would be going way too fast. Transporting the child to the hospital, again, you're like jumping a bunch of steps. Yes, I'm sure that needs to happen, but there's things you can do right here and right now. When we answer a lot of these scenario-based questions, we're going off of mostly that patient assessment. We're going off of like these patterns of behavior that we know. We know how to treat CPR because we know like the steps that are involved. We know how to do a patient assessment, starting from, like he was saying, BSIC and SAFE, all the way down through your ABCs and continuing down. You want to start with the stuff at the top first. Going in that order gives you the most basic needs of that person, taking care of those basic needs. Those are probably going to be the correct answers on 99% of the scenario-based questions on this test. So transporting is important, but it is just so much farther down compared to checking a pulse that it's totally not the right answer at this point. And then we already talked about why the carotid pulse is not correct. For an infant, you use the brachial pulse. Number 6. You were dispatched to a residence for a young female who is, quote-unquote, sick. So that's all you know. That really doesn't mean anything. The patient complains of a rash to her lower extremities and truncal area. Your assessment reveals a small, painful blister on her inner thigh. As your partner is taking the patient's vital signs, she states that she and her family returned from a camping trip 2 days ago. On the basis of this patient's presentation, you should suspect... Okay, so looking at this question, the answer for this is actually Rocky Mountain spotted fever.
Oh my God. See?
So this would be something that you'd want to look back at your chapter on, I believe, like the environmental diseases or environmental issues, because this would be in there along with the snake bites and everything else. Rocky Mountain spotted fever is spread by tick bite, usually. It presents like this. There's a rash in almost everybody starting 2 to 5 days after the bite. So this fits right in. She and her family returned from a camping trip 2 days ago. Allergic reaction and exposure to poison ivy don't quite seem to fit because it's not just the rash. We're also talking about that small painful blister, which you would find in Rocky Mountain spotted fever, but not in just more of a general allergic reaction or even the exposure to poison ivy. That would be like specifically located wherever you touched or wherever you scratched, but you wouldn't have a more distinct like center or blister type formation. The reason why it's not Lyme disease looks very, very specific. You guys should Google it when you have a chance. It presents as what they call kind of a bullseye looking rash. So this sort of overall spotted rash that you get from the Rocky Mountain spotted fever looks a little bit like chicken pox, kind of that like light, slightly raised reddish bumps all over wherever. The Lyme disease type rash is going to have a center that's usually pretty red, and then a couple like concentric rings around it, alternating like red and then pale skin. So it's very unique looking, and it wouldn't look like what we have here, which is that overall rash on the lower extremities and kind of the back trunk area. Yes? So number 7, you arrive at the scene of a motor vehicle versus pedestrian accident. The patient, a 13-year-old male, is unconscious and has multiple injuries. As you are treating the child, a law enforcement officer advises you that the child's parents will be at the scene in approximately 15 minutes. What should you do? So, why is this an issue? Because he's 13. He's underage. He's technically a minor. So what does that mean about his ability to give consent? He legally can't give consent. According to the laws, I mean, it's not that he can't say what he does and doesn't want. It's just that his wishes can't be legally held as consent for a particular medical procedure. His parents have to give consent, or his guardians have to give consent. If the child's parents are not available to be reached or nowhere to be found or way too far away or something like that, what would your procedure be? How would you handle that? Oh, Okay, so how would you handle that? Sorry? So you'd want to treat as well as you could, basically. If you can't get consent, then just like with any other patient that you can't legally get consent from, say if they're unconscious or something like that, you treat them as best as you possibly can according to the normal standard of care that any other person in your place with your same amount of training would give. That's basic standard procedure.
But because he's unconscious, don't you have to like treat him?
Okay, well, see, that's the other question. So, because his parents aren't right there, they can't necessarily give consent right away. They're not at the scene. Maybe you're not able to talk to them. You have to weigh in the balance the question of, what can I do for this patient now? What does he need right now? Is waiting for consent going to somehow cause more of a problem in terms of being able to treat him, keep him alive, that kind of thing? Generally speaking, if you can't get the parents right there and there's things you have to do to save the kid's life or he's going to die, you do those things. So the question kind of becomes, you've got this 15-minute window, what are you going to do? So looking at the answers now, that we've kind of talked about this idea of consent for children, looking at the answers, what ideas do you guys have? So what would we say if D is definitely wrong? Probably A. Treat the child at the scene and wait for the parents to arrive and give consent. That would be B. Do you really want to wait and just leave him there at the scene while he's unconscious for 15 minutes? That's getting to be kind of a long time. If we're talking 2, 3, 5 minutes away, that's one thing. Probably takes you that long to get him into your ambulance and hooked up properly to all the machines. But 15 minutes of waiting in the ambulance when you could be transporting this unconscious, bleeding, oxygen-dependent patient. We're assuming that's what he is based on the scenario that we've been given. You don't really want to wait. You don't know how far you're away from the hospital, so there's a lot of assumptions going on in here. But you probably want to go ahead and transport and have the parents meet you when they could at the hospital. Meeting en route to the hospital, not necessarily the best idea. You don't really have anywhere safe to meet. It's not like, oh yeah, well, I'm halfway down 30, headed towards Baylor. Let me know when you reach the exit for 635. Like, what is that? That's not really doing your job. That's putting yourself, the parent, the patient, all in kind of a dangerous situation by trying to somehow coordinate that. So the answer here would probably be A. Number 8. You and your partner are caring for a critically injured patient. Your partner is controlling severe bleeding from the patient's lower extremities as you attempt ventilations with a BVM. After repositioning the mask several times, you are unable to effectively ventilate the patient. You should do what? So what can we look at knowing, based on this scenario, if you look at the answers real quick, what do we know is definitely wrong? Let's go bottom to top. Is D correct? Do you ever suction for 30 seconds? No. That right there. Even though if you look at it and like, oh, suctioning sounds good, 30 seconds is outside of what you would ever do. Certainly not all at once. So that right there is enough for that answer to be incorrect. Continue attempted ventilations and transport immediately. What do we think of that one? Maybe. Okay, that's fine. B, hyperextend the patient's head and reattempt ventilations. Yeah, when we talk about hyperextend the patient's head, at no point do we ever say open the airway by hyperextending the patient's head. We talk about head tilt chin lift. We talk about the jaw thrust. We don't talk about like all the way back like that. That's not, it's not going to open up the airway anymore, and it's potentially going to cause more problems if you've got a critically injured patient. So probably not B. Look at A. Begin ventilations using the mouth-to-mask technique. Exactly. How is that any better than a BVM? If the problem is something in his airway, if you're not working well with a BVM, then you're not going to get him any more oxygen if you're using a mouth-to-mask. So based on this, we would probably say continue attempted ventilations and transport immediately, which is answer C. Number 9. You and your partner are attempting to resuscitate a middle-aged female in cardiac arrest. Because of the remote location that you are in, you are unable to contact medical control. What should you do? Okay, so I've heard D and A. Why not B? Yeah. So make continuous attempts. It's like, let me not help my patient here. Let me just be on the phone for 15 minutes while we figure this out. That's not going to help your patient. You've tried. It clearly says you are unable. So it's not a question of calling enough times for someone to pick up. It's not going to happen. Asking the husband if he wants to continue resuscitation, that's not how it works. Generally speaking, when is the only time that you just kind of stop and say you're done with helping a patient? So when you get to the hospital and a doctor officially calls that the patient is deceased, right? Or if they have a DNR. So if they have a do not resuscitate order that has been appropriately and legally signed, those are usually documents that have to be signed about once a year. It's a legal thing, and it can't just be somebody writing on a sheet of paper, I don't want CPR or I don't want extreme life-saving procedures. It's a very official document. And if they don't have one that is legal, that is in date, and that is appropriate for out-of-hospital situations, because there's usually two kinds. You've got the in-hospital DNR and the out-of-hospital DNR. If they don't have one that is appropriate for this situation, you can't just kind of stop resuscitating them. And then I think someone said if they're obviously dead, if they have the obvious signs of death, the decomposition, decapitation, some of those other ones that are in your book, obviously then you wouldn't even try to do resuscitation. But as far as we know, none of those things are existing here. So you don't just ask the husband if he thinks you've done enough at this point. He's not the person that's in charge of that. So your two options then are either perform CPR only and initiate immediate transport, or follow locally established protocols or standing orders. Generally speaking, I would say D. So performing CPR only means nothing else. Like you're not trying to give drugs, you're not, if you have access to a paramedic partner that knows how to give IVs and drugs and things, epinephrine, trying to restart the heart, trying to get it going, you're not just only going to do CPR. You're going to follow whatever the locally established protocols are or whatever your standing orders are. Meaning, we talked about medical control. There's that online medical control, which is talking to your medical control, and you couldn't do that. So you go to what's called offline medical control, which is everything that you know how to do according to your procedures and what you have to do, standard operating procedures every day. So that would be the case, and that would be what you would do in this case. Since you can't contact them, you've got to go with what you know. Sorry, the answer would be D. Let me make that clear. 10. You and your partner respond to the scene of a 49-year-old male with acute abdominal pain. As you enter his residence, you find him lying on the floor in severe pain. He is conscious and alert. The patient appears to weigh in excess of 300 pounds. Your first action should be to what? So when we talk about first action, this is where I was talking earlier about how you want to look at your patient assessment chart that we've gone over. And when we say first, we literally mean the first things you do. So if any of these answers had to do with BSI, that would be the answer. Even though it seems to have nothing to do with your patient, even though you do BSI regardless, like it's not that he's 300 pounds or anything else about him, BSI would be first, because your first action at any scene is BSI, making sure you have your gloves or whatever else you think you're going to need, right? What happens after BSI? What else do? You do a scene size up, okay, which includes knowing the number of patients you have, knowing if you need to take spinal precautions, knowing the mechanism of injury or nature of illness, knowing if the scene is safe, and knowing if you need any additional help, right? So of those 5 things that come right after BSI, are any of those covered within these 4 choices? D, request additional personnel before making any attempt to lift him. That would be right up there in terms of one of these things you're supposed to keep track of. So would you ever encourage the patient to walk themselves to the ambulance? No. Never. Would you just kind of say, hey, walk over there and see if you can get on okay? I know they're 300 pounds, and that's not going to be easy for you to lift necessarily, but patients do not walk themselves into the ambulance. If they can walk themselves into the ambulance, then why are you there, right? Either they can take themselves to the ER or somebody around them can take them to the ER. If a patient is called for an ambulance, you don't ever risk and say, well, you're probably okay to walk. That's just not okay. Assessment, then move into the stretcher with a direct carry. Okay. Direct carry. So do you think you and a partner can lift 300 pounds?
No.
That's kind of, it's getting to be a lot. If he's a big guy, he's got the acute abdominal pain, lying on the floor. So he's not making it easy by already kind of sitting in a chair where you can just sort of shimmy him over. You have to lift him up off the floor, all 300 pounds of him, at least 300. We don't actually know. So trying to move him to a stretcher with a direct carry, probably not going to be helpful. And then request the fire department if one attempt to move him fails. He's 300 pounds. He doesn't need like the jaws of life or like a crane to move him. You don't need some of the excessive equipment that they have. Fire department specifically is not required. Additional personnel, though, might be very useful in this case. Let's take a break here for a little bit. Question number 11. A 78-year-old female presents with an acute change in her behavior. The patient's son tells you that his mother has a history of type 2 diabetes and was diagnosed with Alzheimer's disease 6 months ago. The patient's speech is slurred and she is not alert to her surroundings. What should you do? So when we talk about an acute change in her behavior, what are we thinking? Altered mental status. We have a couple reasons right here why she might have altered mental status, correct? So diabetes, what are we thinking? When we know she has diabetes and she has altered mental status, what does that mean? So either, blood sugar either being too high or too low, which would be hyperglycemic or hypoglycemic. She also has Alzheimer's, which is another reason why there might be altered mental status. We don't know what this person's normal level of mental ability is. We just know that there has supposedly been this acute change. Looking at the answer choices, what about A? We know she has Alzheimer's, so should we transport her to a psychiatric facility? No. Even though she has Alzheimer's, we're not assuming that she has a mental disorder that is going to cause her. We just can't assume like that. Yes, she has Alzheimer's. Yes, she may need Alzheimer's care. This whole thing may be because of Alzheimer's. But you don't take them to a psychiatric facility because they have Alzheimer's. Likewise, C is also incorrect. So you don't look at all of this stuff and just conclude, the patient's blood sugar is too high. Of all the possibilities, with the little amount that you know right now, you don't want to make a diagnosis. And an assumption is really what that is at this point, because you don't know if it's too high or too low. You haven't looked at her blood glucose level. And, that's just one possible reason out of the multiple reasons that there are why she could have slurred speech and be unalert. What about D? Is it okay if this patient refuses transport? Why not? Yeah, at this point, they're not mentally competent to give consent, so therefore they're also not mentally competent to refuse treatment. Based on the fact that they are slurred, the speech is slurred, they're not alert to their surroundings. It's that not alert that's really key. They can't legally give consent because for one reason or another, we don't really know why, they are mentally incapable of giving consent at that moment. So the only option is B, inquire about the possibility of head trauma. And that should always be a consideration with a patient that has altered mental status, regardless of any other conditions they may or may not have. Head trauma is a big one that could possibly cause AMS, right? So even though there's these other options that might be causing it, B is still the correct answer because it's the only one that doesn't make an assumption, an incorrect, potentially, assumption about what's causing the problem. Number 12. During your visual inspection of a 19-year-old patient in labor, you see the baby's head crowning at the vaginal opening. What should you do? So what does crowning mean, you guys? It's when you can start to see the head at the opening. You can actually, it's not always like the head, it's something. You can see whatever at the opening. So in this case, when they're actually crowning, when you can look and see that something is trying to push its way out, some part of the baby, should you go ahead and transport right then? It's kind of too late at that point. Your patient is crowning. They are about to move into the second stage of labor, or really, I guess they have. They are like in the process of being about to push this baby out. You're not going to just tell them not to push and transport and hope that that kind of works somehow. So at this point, if your baby's crowning, B is the incorrect answer, or B is an incorrect answer. What about A? Gentle pressure to the baby's head as it delivers. Contrast that with D, which says maintain firm pressure to the head until it completely delivers.
We don't want to push it back. We just want to hold it.
You don't hold it so it doesn't, so you don't like lose it when it comes out.
Okay, so we could probably for sure say that D is wrong, right? Firm pressure, you don't want to actually be pushing the baby in somehow. You're putting a lot of pressure on the head, and why is that a problem? Because you got those soft spots, those fontanelles. There's one, the anterior fontanelle and the posterior fontanelle, and they're both places where the bones of the skull have not completely fused in a baby that young. They don't fuse for multiple months after the baby is born. So when that baby's brand new, like literally about to pop out, you certainly don't want to be putting firm pressure on those soft spots where the skull is not completely protecting the brain. However, A is the correct answer. It is okay to put gentle pressure on the baby's head as it delivers. Specifically, when we say gentle pressure, we're really mostly meaning you want to make sure that that baby does not have an explosive birth. Did we talk about that in class? You don't want that baby to be popping out in a way that's actually potentially going to damage the baby or the mother. So in an explosive birth, the vaginal opening can tear further as kind of the baby just whooshes out. You can have problems controlling it in terms of catching the baby and appropriately supporting them on their way out of the mother. So you really, really don't want an explosive birth if at all possible. That's why gentle pressure on the baby's head, you don't. If you put your hand like this on the baby's head, you got the nice little central, slightly like depressed part of your palm that's going over the fontanelle. So you're not pressing on the fontanelle. But then all around here, the meat of your palm, around the edges, that's going to be on the edge, basically, where it's not the soft spots of the skull, and you're going to be protecting the baby. You're going to be pressing only on the parts that are actually protected by the skull, and you're not going to be hurting the baby as long as you're not pressing really hard. Does that make sense? Why would C be wrong? We know A is correct, but why is C definitely wrong? You never put your fingers inside the vagina. The only possible circumstance why you would do that, remember, is if you have a prolapsed umbilical cord and you're actually having to slightly lift the baby's head or buttocks or something up so it's not putting pressure and constricting the umbilical cord. Remember, a prolapsed umbilical cord is where it actually is coming out. Where it's presenting at the opening and kind of trying to come out first. And you do not want that because that's what's holding all the baby's blood, nutrients, oxygen, everything. If that's coming out first, there's probably a lot of pressure on it because the rest of the baby's not far behind. And you don't want the rest of the baby to be putting a lot of pressure on that and constricting it because that's essentially like cutting off all their blood flow and oxygen. That would be the only time that you would ever put your fingers inside, and then it would be only for that purpose. 13. What is the most appropriate management for an uninjured, semi-conscious, 40-year-old male with respirations of 20 breaths per minute and adequate tidal volume? Okay, uninjured, semi-conscious, so we don't know what happened to him, but he is uninjured, apparently. Semi-conscious, 40-year-old male with respirations of 20 breaths per minute and adequate tidal volume. Looking at his airway and oxygen information. Are his airway and breathing, do they seem to be working properly? Yes. Does that mean you would not give him oxygen? No, you still give him oxygen. Every patient, and if you actually look at the answer choices, they all include oxygen. However, he does have adequate respirations, adequate tidal volume, so you don't need to give him a BVM, right? So A is absolutely wrong because BVM is totally not necessary for this particular patient. Let's see, looking at the rest of them. Position him in okay, the rest of them all have to do with position. So a semi-sitting position, Fowler's position, or place him on his left side. And they all have slightly different oxygen requirements. Okay, so in this case we already said, no, we don't need VVM. We don't want him in the semi-sitting position. Similarly with the Fowler's position, we don't want him to be partially or mostly supporting himself in a sitting position. We'd want to go ahead and put him on their left side. Give oxygen as needed via the non-breather. But that left-sided position is going to be the most secure way to transport. 14. A 4-year-old male ingested an unknown quantity of Tylenol. The child's mother states that the ingestion occurred approximately 20 minutes ago. The child is conscious and alert and in no apparent distress. After contacting medical control, you should do what? So syrup of ipecac wouldn't be wrong. It's just an older mechanism. Activated charcoal would be effective. especially since we know that it's been about 20 minutes ago. If it's been an extremely long amount of time, it's not going to be as useful to give them something like that because it's going to have already started to absorb through their system. So you need to get them as quickly as possible to somebody like the definitive care, meaning a hospital or a doctor or someone who can actually pump their stomach or give drugs to kind of counteract that. But with only 20 minutes ago and the child is conscious, meaning that they can safely vomit something up, the activated charcoal would be fine. What was your question? So contacting medical control would really depend on your specific protocols. If it's in your, depending where you were working, if it was in your manual that giving activated charcoal was okay for these particular circumstances, then you could give it without contacting medical control. In general, better safe than sorry, but like we talked about, that online versus offline, if you already have it, offline medical control, if it's already in your book, is that is standard procedure, you don't usually have to call it in for the online medical control. One or the other kind of thing. Well, that's the thing. It would depend on your protocols in terms of what they had taken if you were allowed to give activated charcoal for it. If you weren't sure, better to call medical control than just to make an assumption one way or another. So in this case, the answer is C. Give the child cold milk. That doesn't work. I don't know if that's an old wives' tale or something, but that would definitely not be the answer here. That's not actual medical care. 15. A 50-year-old male was stung by a honeybee approximately 15 minutes ago. He presents with respiratory distress, facial swelling, and hypotension. After placing him on oxygen and administering his epinephrine via auto-injector, you note that his breathing has improved. Additionally, his facial swelling is resolving and his blood pressure is stable. What should your next action be? So, your patient was stung by a honeybee. He has respiratory distress, facial swelling, hypotension. What's happening? Specifically an anaphylactic reaction. He's going into anaphylactic shock. Clearly he is very allergic to honeybee stings. So you gave him his EpiPen. That's that auto-injector. Breathing has improved, facial swelling is resolving, and blood pressure is stable, which those were the problems that were existing. So at this point, what would you do? Right, okay, so A is not a bad answer. It's something that you would do. You would load them into the ambulance and you would transport. Unless this guy is adamantly, no, I'm not going to go to the hospital. You really, really do want to definitely take them to the hospital. If they're saying no, they don't want to go, you want to try to encourage them. Say, please let us drive you there. Because even if it seems momentarily contained by that EpiPen, you don't want to just assume that everything is okay. So A is not a bad answer. Let's look at B. Visualize his airway to assess for oropharyngeal swelling. It's not a bad answer, right? You're checking his airway. That's okay. You do know that his facial swelling is resolved and his breathing is improved. So oropharyngeal swelling is probably not as much of an issue, but certainly it wouldn't be a bad idea to check. What about C? Notify medical control of the situation and your treatment. You should have done that before. Definitely before you gave the EpiPen, you should have notified medical control. I can't really imagine. I guess there could theoretically be a time when the situation was so dire that you couldn't call medical control first. It's a real gray area because, again, that depends on your local protocols, whether that's necessary or not. But at any rate, C is not, it's not a bad thing to do. You obviously have to tell medical control. But then look at D. Record the time and dose of the injection on the run form. What about that one? Yes, and in fact, that would be the answer because that is the immediate next action. So all of these answers are good, and you could give a justification for any one of them, but when we talk about literally the next thing you should do is record what you just did. Before you load them into the ambulance and transport, we don't know if you've already done that or not, but at this point, because of the fact that his blood pressure is stable, facial swelling is resolving, and breathing has improved, he's not really in critical condition. So he has to go to the hospital, but it's not must do now before anything else kind of situation. Again, isn't a bad idea to visualize for oropharyngeal swelling, but is not required, must do now kind of situation. The one thing you have to do is record what you just did. when you guys have been in the ER, you've seen how the nurses, if there's a code or something, there's always at least one nurse that's got the chart or the clipboard or the computer that is marking down every single thing that happens when it happens. So the doctor will push an amp of epi or something, and he will tell the nurse what he just did, and she will mark down the time. Because keeping those records of what you give is super, super important. And that would be the next action in this case. Number 16, you are dispatched to an apartment complex for a young male with abdominal pain. Your priority upon arriving at the scene should be to. So, priority, that's one of those things we're talking about. What is the very first thing you should do? Do any of these answers involve BSI? I wouldn't really call C BSI, because none of these are specifically talking about like gloves or something like that. However, C is talking about scene safety, which is like right next in line in that scene size up right after BSI. Placing a paramedic ambulance on standby is kind of jumping the gun. You don't really know what's going on. So even though it relates to that whole scene size, do I need additional help, it's going too far. You don't know that you actually need a paramedic ambulance. It's not necessary right now. Notifying the dispatcher of your arrival, it's not really that necessary. You're going to have remarked the time on your forms, but you don't need to call the dispatcher. At this point, your job is not to tell the dispatcher what you're doing. It's to deal with your patient. Quickly gaining access to the patient, though, kind of ignores all of the 5 like scene size up things that you should be doing. So that's jumping the gun. In this case, C is the correct answer. Assess the scene for potential hazards. That's not scene safety. Number 17, shortly after assisting a 65-year-old female with her prescribed nitroglycerin, you note that she has become hypotensive and complains of dizziness. The patient remains conscious and her breathing is adequate. You should do what? So, you've given her nitroglycerin, probably meaning she had chest pain and high enough blood pressure, right? Now that you've given that to her, she has become hypotensive and complains of dizziness. So what has probably happened? Yeah, so maybe that nitro worked a little bit too well. Her blood pressure dropped a little bit more than she could handle at the time. She's hypotensive, she's dizzy, she's probably not getting enough oxygen to her brain. However, she is conscious and her breathing is adequate. So, should you, knowing all this stuff, should you wait 5 minutes and then reassess her blood pressure? No, like waiting 5 minutes, I mean, her blood pressure is not going to go back up magically. So it's not really effective. If you don't do anything, there's no point to wait randomly. Transport her in a Fowler's position. We kind of already talked about how you don't really want to put somebody who is conscious or even, like remember we talked about Fowler's position is mostly sitting up. There's different levels of how far you're sitting up, but essentially Fowler's is a sitting up kind of position. If she's sitting up, is that blood with the oxygen getting to her head? No. What do you do with somebody who's in shock? Shock is hypotension, so what do you do? Place her supine and elevate her legs, which is conveniently answer choice C, which is the correct answer. To finish it out real quick, if you look at answer choice D, you don't need to assist ventilations with a BVM. We know she's breathing adequately. So this is just a question of how would you position her properly. You want to put her in that shock position, which is, you might see it on the test listed as Trendelenburg position. Have you guys heard that term so far? Okay. Remember that particular term because it may pop up on the actual test for you guys. 18. Medical control gives you an order that seems inappropriate for the patient's condition. After confirming that you heard the physician correctly, what should you do? So in this case, B would be the correct answer. When it says advise, that's one of those fancy wordings that they really mean to like just talk to him. They don't mean like to give advice somehow. It's just that they want you to talk to your physician, who, like I said, is your medical control. Saying that the order is unclear and asking for clarification is basically a polite way of questioning their reasoning and hopefully getting some understanding. It's not so much that you're telling them they're wrong. It's really saying, based on what I'm seeing, I don't understand why we did that. I would really like to know what I'm doing before I give it to my patient. Because you are in charge of what happens. So medical control is in charge of the directives that are given, but at the same time, the responsibility also falls with you to properly treat your patient. You've got to kind of have this balance between what do you believe to be the best course of treatment and also what does medical control say to do. You certainly wouldn't just straight up tell the medical control, I'm not going to do that, that's inappropriate to do. Like we said, they probably know more than you do. They may have some extra idea in mind that they haven't told you, they're a doctor. And it's just unprofessional to approach them in that manner. Carrying out the order and then documenting it at the same time is not really advocating for your patient fully. Take that extra step. Advise the physician that the order is unclear. Ask for clarification. Because the possibility is that maybe you didn't properly communicate to them what needs to be done, or rather what you're seeing in the patient. So you may have missed telling them a vital sign, or they may have misheard a vital sign that you told them, or any other particular piece of information. If somehow you didn't properly communicate what they need to make their correct decision, they might be telling you something wrong, not really because of anybody's fault, but just because all the information wasn't there. And that's why you want to continue that conversation. You don't want to just obtain consent from the patient and then say it's good. That's like what we say CYA, it's cover your butt. You got consent and you got medical control, but so technically you're covered, but again, it's really not acting in the best interest of the patient to just carry the order out without double and triple checking and making absolutely sure that this is appropriate for that patient. Everybody makes mistakes. 19. You arrive at a grocery store shortly after a 35-year-old male stopped seizing. Your assessment reveals that he is confused and incontinent of urine. The patient's girlfriend tells you that he has a history of seizures and takes Tegretol. When obtaining further medical history from the girlfriend, it is most important to what? So, real quick here, I want to point out they listed a drug. They may occasionally list drugs in the questions. It is probably to your benefit to know some of the drugs and what they may help treat for. Usually they're going to kind of tell you, like it has it in here, it's seizures, Tegretol. They're kind of bringing those things together for you. In other words, he has a history of seizures, he takes the medication to control them. So they're usually not just going to throw out random like patent drug names at you and expect you to know why a person would be taking a certain medication. At the same time, you will be a better EMT if you take the time to kind of be aware of some of these medications. If you remember now that Tegretol controls seizures, and you have a patient on down the line that takes Tegretol, maybe that'll click in your head and you'll be a little bit quicker on the uptake in terms of knowing some of their medical history or piecing things together. Sometimes patients don't give you a complete medical history, or they leave something out, or maybe they aren't talking to you at all, and so it really depends on what their neighbor or their daughter or their aunt thinks is important for their medical history. So the more information you can already have in your head to help you make those decisions on down the line as an EMT, the better positioned you'll be. So back to this particular question. What do we need to know as far as medical history? Okay, obtain a description of how the seizure developed. That would be important. What about A? Determine if the patient is a known alcohol abuser. Again, it's probably not a bad thing to ask, but maybe not pertinent exactly to what we're doing right now. If we're trying to treat that seizure and trying to, figure out how to treat him properly right now, the alcohol thing is not the most pressing issue. Look at C. Determine when he was last seen by his physician. Not a bad question. I mean, you can go ahead and ask that. Again, more information, the better. Why not? But again, doesn't have to do specifically with this instance right now. Doesn't really matter if he saw his physician yesterday or 2 years ago. It doesn't fix the seizure that's currently just finished. Ask her how long the patient has been taking Tegretol. Again, not a bad question. Maybe, theoretically, if he has been going back and forth on medications, trying to find the right mix that works, maybe he's only been on Tegretol recently, it wouldn't hurt for the doctor to know that, Tegretol is really not controlling his seizures. However, for you for today, dealing with that patient who's just finished having a seizure, it's not the most important question. So B is the correct answer. Obtain a description of how the seizure developed. That's straight up there from your sample questions. Your E, events leading up to the seizure in this case, you'd want to find out all the information you could of how that happened. You were dispatched to a convenience store for a possible cardiac arrest. Upon arriving at the scene, you find 2 bystanders performing CPR on the patient, a 48-year-old male. Your initial action should be to what? So, We are talking about CPR and AED in this particular question. These two bystanders who are performing CPR on the patient, do we know if they're performing CPR well? No, at this point we don't. The question hasn't told us. Do we know if the patient needs CPR? No, the question hasn't told us. All we know is what we see at this point, okay? So when you're first looking at this scenario, you've got two people doing CPR on a patient, but you don't actually know if that CPR was necessary. What of these answer choices looks like the correct one? So let's look at it. A, assess the effectiveness of the bystander CPR. It still doesn't help you know if the patient needs CPR, right? All you know is it's a possible cardiac arrest. So CPR, maybe that person was not very good at finding a pulse. You don't know. You don't know who these bystanders are. So A wouldn't be correct, just because it's not really answering the main question, which is whether or not this guy needs CPR. Like, what does this guy need right now? B, quickly attach the AED and push the analyze button. Wouldn't be a bad thing to do. You do want to go ahead and attach the AED, most likely, if it's a possible cardiac event. Remember, the AED only notices certain heart rhythms. What are those? There's two specific ones that it picks up on. VTach and VFib. So ventricular tachycardia and ventricular fibrillation. So the only problem with that is that it won't pick up if your patient is in asystole, meaning no heartbeat whatsoever. It won't pick up if your patient has a perfectly fine, strong heartbeat, or any of the other possible variations between. It really just picks up on those two main heartbeats, which is effective in terms of knowing when he needs an AED shock, but it's not necessarily effective in knowing if he needs CPR. What about C? Have the bystanders stop CPR and assess the patient. This is meaning have the bystanders stop CPR so you can assess the patient. You're not asking the bystanders to assess. You're saying that you will assess the patient. That would probably be a good idea because, again, you don't actually know at this point if this patient really is pulseless and apneic. You only have the word of those bystanders for it, and we don't know if they're trained in any way. And then D, request a paramedic unit and quickly attach the AED. Not bad. I mean, AED might be necessary. Maybe you'll need a paramedic unit. But again, you don't actually know if this guy's in cardiac arrest yet. You need to get down there and assess the patient yourself before you take all these other extra actions. So the answer in this case would be C. Let's pause for a sec.